As this is an older dog, we make the incision just behind the umbilicus. The fat is trimmed away to give better exposure, clearly separates the muscle. And when we push down with the ovarian clamp, it can't get caught in the clamp. The linea alba is held high and the stab incision made, with the blade handle parallel to the dog. The muscle is elevated and the incision point is extended with straight scissors, keeping the scissors parallel to the dog. Slide your index finger down the body wall, touch the vertebrae, and then slide back up, using your finger like a hook. Don't worry, in time you will be able to find the uterus quickly. The intestine is flatter and the uterus is more tubular. Its size can be extremely variable. Always keep the abdominal fat inside, so don't confuse it with the broad ligament. The uterus is more fragile than the ovary, due to the suspensory and renal ligament. Push down on the body wall to get down to the ovary. Don't worry about pulling on the ovary. The worst that can happen is the suspensory breaks. Do not pull on the uterus to get the ovary, as the uterus can break. Transfer the ovary to your right hand and with your left index finger slide down the suspensory ligament. To the rib insertion, you will feel yourself going round the back of the kidney, at or as close to the insertion push down. Exposure of the ovary should dramatically change. Do not break the renal ligament. We need this to protect the ovarian vessels. Otherwise, we will not be able to pull on the ovary. Now make the window in the broad ligament. Choose a clear transparent area, which is low down and not near the major vessels. Place an atraumatic clamp below the ovary. Hold the ovary with your left hand and walk, not force, the clamp down. Check there is no fat or skin caught in the clamp. And if there is, tease it out while you hold the clamp, without clicking. Once you are happy with the position, do 1 to 2 clicks. Now the weird bit. Place 2 clamps above the ovary and cut, separating the uterus. This improves visibility, access, and later you can check for bleeding safely. Form your Miller's ligature, but keep it very loose. Now gently push the Miller's down at the back and then at the front. Now tighten the Miller's a little, so it doesn't lose position. And now fully tighten the knot. Follow with 4 to 6 ones. I keep the tail short, so they can't get caught in the second Miller's. Now hold the ovary again and move the clamp closer to the ovary. Make sure you have clearance of the ovary. I replace the other clamp, so the tissue can't roll over and get caught in the second Miller's. Form the second Miller's, again keep it loose and then tighten once in the correct position. You never want to put a ligature right alongside the clamp. It has to be at least a slight distance away, otherwise it can't pinch in and tighten well. With this technique, we can check for bleeding in a very safe position. We just remove the clamps, hold the ovarian bursa, and if we have any concerns, we replace the clamp and add another ligature. As you can see here, there is no signs of bleeding. We replace the clamp, again checking we are clearing the ovary, and then I remove with a blade, so I can cut flush to the clamp. As we now know, the ligatures are good and there is no bleeding, so we just release the clamp. I am now making a window in the broad ligament. The uterine vessel stays with the uterus. 2 clamps are placed and we cut between the clamps and ligate the broad ligament. I rotate the clamp so the ligation isn't too close to the clamp. With this dog, we can easily feed up the other side of the uterus. I push down on the body with my left hand to get the ovary and then pull on the ovary to exteriorize. I transfer it to my right hand and follow the suspensory down with my left index finger. If the ligament goes direct to the kidney, you have the wrong ligament, the renal ligament. The suspensory goes round the back of the kidney. The left suspensory is thicker and hard to break. Sometimes I have push under and upwards to break it. Now form the window in the broad ligament, where there is clearly no vessels. Place your clamp through the window and walk it down the ovarian pedicle. Now clamp and separate the uterus. Form the millers, keep it loose, nudge down into position and then tighten. Release the top clamp, clean away the blood that was trapped. Hold the ovary and move the ovarian clamp closer to the ovary, form the second millers. Position and tighten. You don't have to use the crush bed from the clamp. Position of the ligature is more important. Remove the clamps, check for bleeding, replace the clamp. Check again you have full clearance of the ovary and then remove ovary. Now make your window in the broad ligament, keeping the uterine vessel with the uterus, and ligate the broad ligament. I always avoid crush beds in the uterus. I have had too many damaged, bleeding uteruses. First I place a surgeon's, as this is less likely to cut through than a miller's. Then I place the miller's after the surgeon's, followed by transfixing ligatures. The transfixing ligatures are focused on the uterine vessels. When passing the needle, angle the needle so it is going away from the vessels, so you don't accidentally pierce the vessels. Now remove the uterus and check for bleeding. Nudge the uterus back in and check again. I close the muscle with a continuous pattern. Halfway down, I place a surgeon's knot, or I could have placed an aberdeen. This is for extra security. The fat is closed with a continuous pattern, with the knot buried. To bury the knot, go deep superficial on the first side and then superficial deep on the other. Then the first pass is deep superficial. To close the dead space, I go through one side of the fat and then take a nick of the muscle, before going through the other side of the fat. This is not essential but helps to prevent seroma formation. The next layer is the intradermal. First hide the knot. In this case, I took a bite cranial, through the fat, coming out in the intradermal position. Try and leave a small space at the end for burying the knot. For burial, the needle is passed close to the knot and through the small hole. Pull with some force on the suture, but mainly push the skin over the knot with forceps.